Go ahead.
So now you have got the access.
So is my screen visible?
Yes, it is.
Okay. First of all, I'd like to thank your society, the ALS Care, for inviting me to speak on this topic about tracheostomy care. I'm Dr. Anjoo Choudhary. I'm an airway surgeon practicing in Mumbai at SEPI Hospital, SRCC Children's Hospital, and few other hospitals that I am attached is Wokhard Hospital at Bombay Central and Wins Hospital in Borivali. So, as we start talking about tracheostomy care, can you see my slides changing?
Yes, yes.
Okay. So this is SEPI Hospital at Churni Road. This is SRCC Children's Hospital at Haji Ali. And these are my team members, Dr. K.K. Ezi and Professor Philip Monier, who trained me under this topic for airway surgery. And we've developed a department of airway surgery at both these hospitals. Now, we talk on ALS with tracheostomy. When do these ALS patients, the community that you have formed, when do they need tracheostomy? Especially when they start showing breathing problems or swallowing problems. This can be connected, as in they might be starting to develop some lung muscle weakness, which starts to show as difficulty in breathing, where we need some kind of support to be given to the patients, or they start having swallowing problems where they cannot gulp liquids or solids or semi-solids, and they start coughing on taking these, or they find it really difficult and something is stuck in the throat, or sometimes they can present even as pneumonias, which means that whatever they are eating, instead of going into the windpipe, food pipe goes directly into the windpipe and they develop pneumonias. So these kind of patients will need a tracheostomy support. Now, what are the types of tracheostomy tubes? So these are the two main types. The one shown here is a curved. Both are types of curved tracheostomy tubes because they have a bulb here, which goes inside the windpipe. This one is a different type which has a subglottic suction attached. So any secretions that are collected above this cup here can also be suctioned through this suction cannula separately. This one is a plain cupped tube. This is the cup and it does not have a subglottic suction. So both can be used for patients who have swallowing issues in whom the secretions go into the windpipe. Now, these are types of uncuffed tracheostomy tubes. These are for those who are having purely breathing problems, but usually they are connected. So here, if we see, there is no cuff attached here. So this is plainly for breathing. This is a type of a fenestrated double lumen tube where there is an outer cannula and an inner cannula, and this is for inserting. So these are double lumen tubes. So these are two types of uncuffed tracheostomy tubes. Now, if you see how it goes into the windpipe, so this is an example of a cuff tube. Here the cuff is inside. Whenever the patient tries to swallow from above, if something even enters into the windpipe, this cuff protects from it going down into the lungs and causing aspiration. While this is an example of an uncuffed tube, so here there is no bulb. So if the patient is eating something and it goes into the windpipe, then there is a chance of going into the lungs. But if it is being purely used for breathing issues, then a cuff tube can also play a role. So if we try to understand, if we try to use these kind of speaking valves, the purple thing is a speaking valve. The speaking valve will work on a cuffed tube, will not work on a cuffed tube because if the cuff is inflated, the patient cannot speak with a speaking valve. It can work with a cuff tube, but it has to be a fenestrated tube. So these are the speaking options which can be given to patients, these valves and fenestrated tubes.
Can I interrupt in between, Dr.
Sure.
Anjoo? So, as you're saying, this speaking valve cannot be placed in the cuff tube, and we need
Yeah.
to have a
So
fenestrated tube for that.
yeah, you can have a fenestrated tube. The fenestrated tube will have a disadvantage that something will still keep leaking inside. So if there is an aspiration issue, then these are risky to be used. So we recommend that for aspiration patients, they should be on a cuffed tube. But if they want to speak, they can uncuff the tube for a little while, suction immediately after that, use a valve and start speaking. But again, after some time, they have to remove it and inflate the cuff again. So whenever the cuff is inflated, the speaking valve is not going to work. But they need a cuffed tube because the prevention of aspiration is more important than speech in these patients. Because if they develop pneumonia, then it's a very difficult situation to treat. So with aspiration issues, a cuff tube is the only answer, and the speaking valve works intermittently for them. Whenever they deflate the cuff, they can talk with the speaking valve. I hope it is clear.
Yes, yes. Thank you.
So we may move forward. Now these patients require a lot of care of the stoma. Stoma is the opening where the tracheostomy tube enters into the neck, because this is the site where infection goes inside. So whoever is taking care of these patients, whether they're the caregivers or the nurses or anyone else, they have to follow on proper hand washing, hand sanitization protocols. They have to wear sterile gloves, use sterile gauze. They need to change the dressing daily and more frequently if it gets soiled with secretions. They need to change the straps also frequently, like at least weekly or more frequently if it gets soiled, because this is also a source of infection. Then in case of granulations that develop around the tube, they have to regularly apply antibiotic and steroid ointments. Something like a gentamicin is an antibiotic and clobetasone is a steroid. They have to mix it together and use a earbud, which Johnson's earbud. They can use this cream and apply on the skin around. This will reduce the granulation tissue around the tube and reduce the infection. Sometimes if the infection is too much, then we need to start them on appropriate antibiotics, which is based on the culture report. We introduce a swab into the tracheostomy or try to remove the tracheostomy and collect the swab from the trachea within and then send it for culture. And after the culture report, we know what organism is growing inside and we give appropriate antibiotics. These will reduce the granulation significantly. Okay. So this has to be done regularly for these patients. So I'll give an example with this this patient does not have ALS, but this is for an example because he's a cooperative patient. He has allowed me and given me permission to share this video. So for proper stoma cleaning, so I'm using a sterile gauze with sterile gloves and some antiseptic solution like sterilium to clean the stoma. This has to be done daily. Then daily dressings.
So daily we are applying that combination of the uh, that antibiotic and the steroid as per this
Uh,
video, or this is
if the patient has lot of granulation tissue, then it needs to be applied twice a day also. If you think that the skin is very clean, there are no granulations, then you cannot use it daily. It's
so
on
then
an SOS basis.
okay for normal if there's no granulation, normal dressing daily it should be done with betadine.
Yeah, with an antiseptic solution. Clean the area with a sterile gauze with an antiseptic solution. Let it dry for some time. This area is usually moist because it keeps on leaking secretions around. So you have to keep this area dry. Your aim is to keep it dry. So you first clean it, let it dry, and then put a dry gauze piece. You don't need to apply anything on the gauze piece per se every day because we need we need that area to be dry and let it soak. The gauze should soak all the secretions. If the gauze piece is soaked a lot, then we need to change it more frequently. Otherwise, once daily is also okay.
Okay, okay.
So keeping this moist gauze over the stoma helps the patient breathe through the humidified air so that the secretions do not dry inside. Sometimes they can use the HMB filter, but it adds to the cost of the patient because that gets blocked and needs to be changed in every 24 hours or 48 hours as soon as it gets blocked. But this gauze or a sterile handkerchief, which can be washed daily with boiled water and all, can be used frequently and does not add to the cost of the patient. So the patient should not keep the opening directly exposed to the environment because it will introduce germs, infections around, and also the air that he breathes in will not be humidified. So that this wet gauze piece or handkerchief or a bib tied to the neck will keep the area humidified. Then regular suctioning. Okay. So suctioning is as and when required. Some patients have lot of secretions and they need very, very frequent suctioning. Some patients can be managed with once a day suctioning. It has to be decided by checking the air blast frequently. You keep your hand over the tube and you check the air blast on the back of your hand. If the blast is good, that means the tube is not blocked. Then you can postpone your suctioning. If you get this kind of sound, that means there are a lot of secretions in the tube, then you have to do the suctioning frequently. Now, in case of a blocked tube, what happens if the tube gets clogged with secretions and the patient cannot breathe? Then you pinch the catheter and insert it up to the tip, suction while withdrawing, recheck the air blast at the back of your hand. If there's no improvement, then you can instill 0.5 cc of soda bicarb. This will dissolve the secretions inside, and only 2 to 3 drops are enough. With a syringe, you can insert and then resuction, and then try to check the air blast again. Mostly, it will be get suctioned and the air blast will improve. But if it doesn't, then you can nebulize with saline. If you keep the nebulization mask here, so that whatever is blocked here, the dissolved saline will neutralize it, and then you try to resuction it. Again, if there is no improvement, then you have to remove the tube and change the tube, which I'll show. So this is how we do it.
Isn't that soda bicarb should be used very, very rarely?
Yeah, I mean, if it's
Only in the
getting
case of
clogged.
emergency, you are saying.
Yeah, yeah. But everyone who's taking care of these patients have to know these basic things, because every time you may not be able to rush these patients because they are bedridden. You can't mobilize them. So all these precautions have to be known, and these techniques have to, everything have to be kept ready on the bedside of the patient when you take care of these patients. Okay. So in case
So
you,
normally,
yeah,
yeah, sure, sure. Normally, what we have been doing as a group and as in our personal journey also, that instilling zero point 0.5 ml of NS solution every during every sectioning. And before, prior to that suction, zero point 0.5 of NS, depending on how much dry it is, and then doing an embu of for 4 5 embus, and then go ahead and do the suction. So
yeah,
we follow that regular for every suction, unless and until there are very liquefied secretion where we don't add. Otherwise, every other person is also doing the same thing, and nebulize. That's one key
yeah.
area, I think. So soda bicarb, I
The
want to
key is that
understand.
you should.
soda bicarb, in case we use for the emergency situation, it should be diluted or it should
No,
be
it can
given?
be taken directly. It can be taken directly.
Okay. Okay.
It
And
can,
then
even if it goes inside, the patient will cough, and that cough will act as like your umbu, how your umbu acts. It will mix with the secretions inside, and that will act as similar to your umbu. So those secretions will start dissolving with the soda bicarb, and then if you suction, it will come out easily.
and after the suction, do we need to complete it with a nebulization?
No, you don't need to. You don't need. You can
Okay.
nebulize prior to your suctioning, like how you have been instilling normal saline drops. You can nebulize directly with a mask or a T-tube catheter. If you have that catheter mount or a mask, you can keep it here and nebulize with normal saline. 5
Okay.
ml of normal saline in the nebulized form will reach directly into the lungs on the tracheostomy tube, around the tracheostomy tube, and it will dissolve all the secretion, and then suctioning will become very easy for you.
Okay. Okay. Thank you. Thank you so much.
Hello, ma'am.
Yeah.
Uh, about sodium bicarbonate, I think I heard it right. How many times we can use it in a day?
You can use it frequently, but as I told you that giving nebulization is a better option, because the nebulization will have normal saline, which are normal secretions of the patient's body. We are just trying to give in nebulized form, so that's a better way to do it. So if you are doing that regularly, your use of soda bicarb would be very, very minimum.
Yes, ma'am. We are doing saline. We are using saline daily. Nebulization
Yeah,
saline.
so normal saline being the normal secretion of the patient also is basically normal saline. So it is not harmful. You can use it multiple times. So first priority should be regular nebulization with NS. Even with that, if you can't do much, then you can put soda bicarb.
Okay, ma'am. Thank you, ma'am. And secondly, ma'am,
Okay.
around the stoma,
Then in a case where the tube is completely full. Yeah.
ma'am, as you said, usually that the dressing gets soaked up with secretion. It usually happen, or means secretion usually get out from the stoma. It happened to my patient. Is it
Right.
normal or not normal? Uh,
Yeah, see, if the stoma is big and the tube size is small, then they will leak out through the opening. If the patient has lot of aspiration, then and the tube size is small, then again there is a lot of space around, so a lot of secretions will ooze out from the stoma. If there is lot of infection around, then the reaction to the infection is increasing in secretions. Then they will leak out again. So your steps would be, first you change the size of the tube, you keep the cuff inflated, you send a swab so that you can treat with appropriate antibiotics, you check the dressing regularly whether there are granulations around. These all will help in reducing the secretions. There are also certain medications now available which can be given to reduce some secretions and help in some aspiration also. But they have to be given in after asking your neurologist whether it's safe to be given to your patient or not. They will help in reducing the amount of secretions in the airway, but it will also reduce the secretions in the mouth and everywhere else, because it will act everywhere in the body. So you have to discuss with your neurologist, and in certain cases, these are very helpful.
Thank you, ma'am. I have actually
Okay.
changed my tracheostomy. TT size was 7 and changed to we have changed to 7.5.
Yeah.
Uh,
But
so, but still,
you've not noticed
yes,
that the difference in secretions.
yes, ma'am.
So it must have improved, right?
Ma'am, there is a means uh, as before. पहले भी उतना ही आ रहा था, अभी भी उतना ही आ रहा है. Means
अच्छा,
it
पहले
is
भी उतना
same.
ही था, अभी भी उतना ही है.
हाँ हाँ, स्टोमा से उतना ही
ओके.
निकल रहा है.
आप हाँ, तो इसका मतलब है उनको बहुत ज्यादा. इज इट ओके इफ आई टॉक इन हिंदी, इफ दैट इज ओके विद?
नहीं, बल्कि I would prefer we should talk more of a Hindi and मतलब
ओके ओके, नो प्रॉब्लम.
ठीक है, हम
सो
इंग्लिश दोनों
अगर
क्योंकि because there are people other
ओके,
also.
या सो
Okay.
अगर पहले भी उतना ही आ रहा था और अभी भी उतना ही आ रहा है, इसका मतलब है उनको सेक्रीशंस बहुत ज्यादा सेक्रीट हो रहे हैं और आपकी ट्यूब चेंज से वो फर्क नहीं पड़ रहा है. तो आप एक सबग्लॉटिक सक्शन वाली जो ट्यूब मैंने आपको बताई थी, आप वो वाली ट्यूब ले सकते हैं. आप उनकी ड्रेसिंग ज्यादा फ्रीक्वेंटली चेंज कर सकते हैं. और आप इन्फेक्शन के लिए चेक कर सकते हैं कि इतने ज्यादा सेक्रेशंस उनको क्यों बन रहे हैं। फिर आप अपने न्यूरोलॉजिस्ट से, जो ड्रग की मैं बात कर रही हूँ, आप वो पूछ सकते हैं कि उनको सेक्रेशंस कम करने के लिए वो मेडिसिन दे सकते हैं या नहीं। उस मेडिसिन का नाम है ग्लाइकोपाइरोलेट।
ओके मैम।
अगर मैं आपके ग्रुप में वो मैसेज भी कर सकती हूँ, तो आप वो आपके न्यूरोलॉजिस्ट से पूछ सकते हैं कि
नहीं,
अगर वो सिलेक्ट
काफी लोग लेते हैं वहां पर
तो हम वो
ग्लाइकोपाइरोलेट। हमारे
ग्लाइकोपाइरोलेट
many of our patients in the group are taking it, but we
या
don't prefer because it dries out everywhere. So I
या
always say that avoid it as much as possible.
Yeah, but for select group of patients who are not responding even after changing of tube and taking good care of the stoma, अगर कुछ पेशेंट्स को बहुत ज्यादा
बहुत
सेक्रेशंस
ज्यादा
लीक होते ही
secretions
जा रहे हैं, तो आप उनको ग्लाइकोपाइरोलेट दे सकते हैं। अगर
SOS.
हम इस पे आगे थोड़ा बात करें, अगर हमारे पास टाइम है, तो अगर ऐसी सिचुएशंस है जिसमें हम एस्पिरेशन की रिस्क बहुत ज्यादा है, सारे सेक्रेशंस बाहर लीक हो रहे हैं, अंदर भी जा रहे हैं, तो सबग्लॉटिक सक्शन वाली जो ट्यूब है वो ज्यादा हेल्पफुल है एस्पिरेशन को प्रिवेंट करने में। और ऐसे भी सर्जरीज हैं जिससे हम एयरवे को और ब्लॉक कर सकते हैं, जिससे सेक्रेशन आ ही नहीं, आगे नीचे की तरफ जाए ही नहीं। यानी हम दोनों कॉर्ड्स के बीच में एक ब्लॉकर और मोल्ड रख सकते हैं सर्जिकली, जो एक माइनर सर्जरी है जो मुंह से की जा सकती है, और हम उनके एयरवे को ब्लॉक कर दे तो सेक्रेशन उसके बियॉन्ड जा ही नहीं सकते। सो अगर किसी को लाइफ की रिस्क है और बहुत ज्यादा एस्पिरेशन की रिस्क है, तो हम ये मोल्ड वाली सर्जरीज कर सकते हैं ताकि उनकी लाइफ को रिस्क नहीं हो। ऑफ कोर्स इससे उनकी वोकल कॉर्ड्स ब्लॉक हो जाएगी, तो उनकी बात करने की क्षमता चली जाएगी। ये बात उन्हें समझानी जरूरी है। लेकिन कुछ पेशेंट्स जो इतने ज्यादा परेशान है सेक्रीशन से, या उन्हें उसके निमोनिया की रिस्क है, तो हम ये सर्जरीज ऑफर कर सकते हैं।
You can relax. आराम से आओ।
ओके मैम। ओके मैम, थैंक यू सो मच।
नहीं, वैसे यूजुअली तो जब ट्रेकियोस्टमी पे ALS वाले पेशेंट्स जाते हैं, 50% से ज्यादा उस टाइम तक अपनी वॉइस मतलब कि मतलब स्लर्ड होके खत्म हो जाती है। सो दैट आई थिंक इट्स अ
जी।
गुड
सो
सॉल्यूशन।
सो एनीवेज जब वो बात नहीं कर रहे हैं, तो उनकी मेन प्रायोरिटी रहती है उनको एस्पिरेशन से बचाना, उनके सेक्रीशंस कम करना। सो उन इन केसेस में ये जो सर्जरीज हैं, ये इन्हें हम पोटेंशियली रिवर्सिबल कहते हैं। बट आपके, क्योंकि हम एएलएस की बात करें, तो हमें रिवर्सिबल सर्जरीज की जरूरत नहीं है, क्योंकि ये डिजीज भी रिवर्सिबल नहीं है। आगे जाके इनकी प्रॉब्लम्स बढ़ेगी। सो इससे ज्यादा आगे भी हम बात कर सकते हैं, जिसमें हम इरिवर्सिबल सर्जरीज करके उनको एक परमानेंट ओपनिंग दे सकते हैं, जिसमें एस्पिरेशन की कोई रिस्क नहीं होती, जिसमें हम पूरी लैरिंग्स और एयरवे को टोटली सेपरेट कर सकते हैं। ब्रीदिंग उनकी चालू रहती है ट्रिक्योस्टमी से, पर उनके सेक्रीशंस बिल्कुल इन पे नहीं आते। ये उन पेशेंट्स के लिए है जो बहुत ज्यादा सफर कर रहे हैं, और हमारे पास मेडिकली और कोई दवाई भी नहीं बची है
इज इट
उनके सेक्रीशंस कम करने के लिए और उनकी लाइफ को सेफ बनाने के लिए।
okay? I like to add here. Is it something which you have done in any of the ALS patient or this kind of irreversible?
नॉट इन एएलएस पेशेंट्स, बट फॉर अदर न्यूरोलॉजिकल कंडीशंस, जैसे स्ट्रोक है, अगर
अच्छा।
स्ट्रोक है, हमें पता है कि स्ट्रोक से रिकवरी नहीं होने वाली, तो हम उस टाइम पे वो ब्लॉकर डाल देते हैं, ताकि पेशेंट्स की फिजियोथेरेपी चालू रहे, वो वर्क करते रहे और एस्पिरेशन की रिस्क ना रहे उन्हें।
That's good.
और वो भी बात तो नहीं कर पाएंगे, तो अगर हम मोल्ड या स्टेंट से ब्लॉक कर देंगे तो भी सेफ रहेंगे।
Okay, okay. Thank you so much.
हाँ, अब तो नाउ कैन आई कंटिन्यू इन इंग्लिश?
हाँ हाँ,
Okay.
ऐसे क्यों करेंगे?
So if the tube is completely blocked and despite your suctioning and nothing is working, then we know that somewhere we have to take an action and remove the tube and change it. You might not have the time to go take the patient to the hospital. Then you need to learn these few steps as life-saving measures. So if the I will not. This is more for ENT surgeons, so I would not talk of change by railroading. I'll go to your patients will usually have a mature stoma. Then you will be able to change the tube by this method. सो ये पार्ट मैं हिंदी में भी बताना चाहूंगी क्योंकि ये इम्पोर्टेंट है। अगर ये ट्यूब बिल्कुल ब्लॉक हो गई है और सक्शन से नहीं खुल रही है, तो क्योंकि ये हमारी पुरानी ट्यूब है तो यहाँ पर स्किन आ चुकी होगी, तो हम ट्यूब को निकाल सकते हैं, पेशेंट की गर्दन को एक्सटेंड करके ये स्किन को स्ट्रेच कर सकते हैं। ये इस ओपनिंग के थ्रू पेशेंट ब्रीथ कर सकता है। तब तक हम एक नई ट्यूब जिसपे जेली लगा के हम ट्यूब डाल सकते हैं। ये लाइफ सेविंग मेजर है, इसलिए सभी पेशेंट्स के रिलेटिव्स जो उनकी केयर करते हैं उन्हें ये स्टेप आना चाहिए। Now yeah.
28 days. Okay. Yeah.
Yeah.
This was my next question. Thank you.
Okay. So there are two types of there are two types of tubes. The PVC tube, the tubes that I am showing in my presentation is a PVC tube, polyvinyl chloride. The shelf life of that tube is 4 weeks or 28 days. So these tubes, these cuffed tubes need to be changed frequently, that is every 28 days. That can be done in a hospital setting, or if you are confident, then the way I have shown in the video, you can do it with some nursing support at your bedside also. There are other kinds of tubes which are called silicone tubes, puffed silicone tubes, which can be used. Now, these tubes have a longer shelf life, about 9 months to 12 months. So sometimes in certain patients, when we know that this is an irreversible condition like an ALS, we can advise a silicone cuffed tube to these patients, and which can be changed in the hospital once, and then for the entire year, you don't need to change it if you're taking excellent care of the stomach. So these are some training instructions for the patients and caregivers before discharge. I can share this with you on your group. This is in PDF format, and these are exactly the same points that I am saying, but in a nutshell, it is written in this. So you can directly go through them. Whoever not seeing this presentation can go through this. Okay, so this ends my talk on tracheostomy care. And if you have any airway related queries, then you please visit our website. This is Mumbai Airway Clinic, where many of your other doubts will get answered. And I'll be happy to answer all your queries on my mobile number as well.
Thank you so much. You have taken such a exhaustive details of कितना अच्छी तरह से जो हम ALS में तो tracheostomy का तो it's a long term thing which we need to manage, and I think most of the patients get into that stage. तो आपने बिल्कुल practically जहाँ जहाँ चीजें हैं ना, you have taken those points rather than anything else. So thank you so much. इतना अच्छी डिटेल तरीके से. I'm sure everybody else would also have enjoyed. Or we can start the questions answer.
Sure.
You have time, Dr. Anjoo?
Yeah. Okay. Some of your questions are on my mobile.
I can ask people to ask first here. If then we can move on to. Okay.
Yeah.
So anybody would like to ask a question? Prem sir, would you like to ask your question?
Thank you, Doctor. I think your talk was very, very informative. I have a question that is slightly off the track. My wife is an ALS patient for the last 8 years, and she's doing quite well comparatively. She wants to think about removing the tracheostomy. And most of the neurologists don't recommend that, but she still wants to try it and think about it. So her question was, what are the basic process one should start doing in order to get into this process of going back without the trachea?
So my primary question would be whether the need for tracheostomy is over now. If you can answer this objectively, that now the need for tracheostomy is not there, then we can think of the next steps. So your wife would need a tracheostomy if she has any swallowing issue or breathing issues. So are these two issues settled?
Swallowing issue, I mean, she can swallow slightly better now, I think since the last 2 years, but the breathing, she cannot continue like for long without the BiPAP. she
Okay.
needs the BiPAP all the time, most of the time.
Okay.
I mean, during some exercise or therapy, you can remove it for 5-10 minutes kind of thing, but not beyond that.
Yeah. So primarily there is a need for some support that your wife needs. That is one question, one part of the question. So she needs the BiPAP. So there are ways where we can put the BiPAP through the nose and mouth, which probably before doing the tracheostomy she must be on. Okay. So you can block this tracheostomy, put the BiPAP here and see whether she behaves well with that or not. That will give you an idea. Is she on an uncuffed tube now?
She tried all sorts of tubes. Now she doesn't use the cuffs at all now. She can
Okay, so the
do
cuff is
it.
different.
Yeah.
And is she on a peg feed or she's taking orally?
She does. She's mostly 90% peg feed, but she does. We do give some juice and things like that to the mouth.
Okay. So again, we move back to the basics of this. So airway, the vocal cords have three functions. Okay. The vocal cord is at this level. For breathing, it has to open completely. For talking, it has to close completely. And the third important part is prevention of aspiration. So when you eat, the third part is to close completely so that nothing goes into the windpipe and everything goes into the food pipe. So for ALS patients, the problem is aggravated because the lungs also contribute towards breathing process. So their lung muscles are weak. So for her, if she is not opening and closing her vocal cords properly, and she is not using her lung muscles properly, then the BiPAP that I'm talking about will only be partly contributing to her wellness by reducing the time that she needs the tracheostomy. But for prevention of aspiration, the tracheostomy is a must because there is no other way by which you can get out her secretions if you remove the tracheostomy tube. So if you tell me that a BiPAP is working for her through the mouth and nose also, but for swallowing, if she's on peg feeds for 90% of the times, then if you cannot give her food orally and there is a risk of aspiration, then you will not be able to get the things out. Do you understand my point?
Yeah, yes.
Yeah. So for giving her a midway, what we can do is because she has an uncuffed tube, she can keep a cap over it. She can use a BiPAP for most of the times through the mouth or nose if she becomes comfortable with it. She may be able to communicate if because this is blocked, then she may be able to talk a little better with the BiPAP mask on. But for swallowing, whenever she'll try to eat, there's a risk of aspiration. So removing this tracheostomy is like taking a big risk for her. That's why most of the neurologists are saying no to that. So if you say that she is taking 90% of her food orally and only 10% goes through the peg, then I would still be okay giving her a trial. But what you're saying is most of the food is going through the peg. That means her swallowing here is not working properly and she is at high risk of aspiration. Aspiration is a bigger threat to life than a breathing issue.
Okay.
Because we have options of giving breathing than a mouth pipe that is an endotracheal tube, a ventilator, and many more things. But once an aspiration happens, it's a chemical pneumonia, which is very difficult to treat. So taking that risk would be extremely difficult. So my suggestion would be you keep working with the swallowing therapist, and if they say that she is swallowing better and most of her food is going orally, very little is going through the peg, then we may revisit this thought process. But as of now, I would agree with the neurologist that with this risk of aspiration, we cannot go ahead and remove the tracheostomy. I'm sorry, this would be disappointing to you, but you will have to explain your wife that this is the situation that she is in right now. She can work on her swallowing muscles, and we will revisit on this discussion later.
Thank you very much, doctor.
Okay.
Thank you very much.
My pleasure.
Next question.
Any other questions?
Yeah, Prem sir, can you take those questions which are, or Bharti, would you like to take, which we have got from the group?
Okay, I can probably ask that questions. Okay, tracheostomy granulation issue. I think we
Sure.
talked about it. I think types of tracheostomy tube, that is also doctor has covered it. Option to speak while on tracheostomy, I think doctor has already covered that also. Saliva secretion coming out of tracheostomy stoma. I think you've covered that. Fifth question is, my father has, okay, this may be a new question. My father, this is Bharti's question. Bharti, you want to ask or should I just continue? Okay, I'll continue. My father had bleeding issue during tracheostomy tube change. Inside the throat, above the cuff, and granulation happened at that site. It caused several bleeding issues later too. How to prevent that or care for that situation? That's the question, doctor.
So the bleeding is through the granulations. Okay, so granulations are not just around the stoma. They are also inside the trachea or the windpipe where the tracheostomy goes in. Usually these are suprastomal granulations because of rubbing of the tracheostomy tube. So my suggestion would be that they can use a softer silicone tube for her, which causes less rubbing inside, and that will create less trauma. And they have to once visit an ENT who will try to remove all the granulation tissue from around the stoma and also the suprastomal, that is above the stoma, the area where there are a lot of granulations. They have to remove it completely once and then change it to a softer tube and then take care of the tracheostomy. She should not allow infections to occur around the tube, and this will prevent this bleeding while suctioning or while changing of the tube. So if you are doing it at home, I don't think it will be possible for you to remove those granulations which develop above the tube. So this has to be done by an ENT or airway person, because these have to be removed either orally with instruments inside or through the stoma by removing the tracheostomy. So if there are a lot of granulations, then these cannot be contained by only local measures. Okay, so she has to visit an ENT for doing all that.
Yes, doctor. Actually,
Yeah, go ahead, Bharti. We cannot hear you, Bharti. Can you come closer? Speak a little louder.
Is it now audible?
Yes.
I'm having bad throat. Yeah. So when this happened, we did bronchoscopy and we took father to the hospital. They did not check the stoma area. They did bronchoscopy of the whole lungs and said he's doing fine. But when again they did the tube change, it bled a lot. So we moved to the silicone tube and we kept the silicone tube for 1 year because of its unavailability. But when we removed the tube again, there was a lot of bleeding. So now we are following 2 months. Every 2 months we are removing the silicone tube. Yeah, a softer tube is making little difference. And now the granulation, last time it did not bleed. So there was bleeding issue for five times, I think.
Okay.
It was
So
very tough.
granulations can occur, as I said, can be here or suprastomal. Sometimes they can also, with a cuff tube, they can also be below, I mean, where the cuff lies. If it's inflated for a very long time, it will rub on the mucosa inside, the skin inside the windpipe. And when you deflate the cuff and remove it, these granulations or the injury to the mucosa will start bleeding. Okay. The bleeding can also be because the tip of the tracheostomy kind of rubs inside somewhere, especially when the patient moves a little, it keeps on rubbing. So certain patients have a different anatomy, as in the windpipe is not really straight. So maybe the curvature of the tube is hitting the trachea or the windpipe somewhere, which is causing more bleeding. So yes, frequent change of tubes will help. Changing the type of silicone tube will also help because every tube has a different curvature. Doing it under bronchoscopy guidance is a good idea because they can then see inside. They don't need to go up to the lungs every time. They just have to check the suprastomal area, stoma, and up to the tip of the tube. They can see only till there, and then they can apply ointment from within to reduce this bleeding. Okay, so certain patients have tendency of developing more granulation tissue, especially if they are diabetic. And as I said, the tube is of a different curvature as compared to the windpipe. So control of diabetes and control of infection will also reduce this bleeding next time that you go. And control, I mean, frequent changing of tubes is another option.
Yes, thank you.
My pleasure.
Okay, Vishnu has two questions, doctor. Cleaning of inner cannula, precautions to take during that time.
Okay. So a double lumen tube has an outer cannula and an inner cannula. So there are always two inner cannulas provided with a patient. This is one red color and one transparent or white color. So what we suggest is that when you remove one type of cannula to be cleaned, you immediately insert the other one temporarily so that crusts do not develop within the outer tube, because changing of the outer tube is way more difficult than changing or cleaning the inner tube. So that's why they provide two tubes. So always when you remove the inner cannula, suction the outer tube immediately and put the second cannula back again. Then you take your inner cannula, use a rounded brush that is given with the tube, or sometimes you have to buy it separately. It will clean the whole inner tube from within, from the up to the bottom. Do it multiple times. Use running water, uh, or you can dip it in boiled water and remove those crusts inside, and then lubricate it and insert it. Then you remove the second alternate inner cannula. You remove it and then insert your inner tube. So this should be the process.
Thank you, doctor. The second question Vishnu has is carrying pals to the hospital for it. It is really a tough experience for pals. What are the risks to avoid if changing at home?
Yeah. So again, this is a difficult thing because every patient and their anatomy is different. So it cannot be a generalized thing that you can change a tracheostomy tube at home for every patient. Some patients are going to be very easy. Some patients are going to be difficult. So what we recommend to our patients is the first tracheostomy tube change should be done by an ENT person in the hospital setting, and because they will be able to judge the amount of granulation tissue, the damage inside the trachea when they do it, and they will be able to guide you whether this is an easy tracheostomy change or a difficult tracheostomy change. Then they can train the caregiver. I mean, this is what we do at our center. We call the caregiver inside during the tracheostomy tube change and try to tell them that because this is a long term problem, you cannot get your patient here every time. We train the caregiver as well as the attending nurse if they have someone. They stand there and see the whole process. Then the third time, we allow them to do this change in front of us with me standing behind and observing what they are doing. At the fourth time, they become confident. But sometimes what we tell them is, you can keep us on a video call because this will give you confidence to change the tube at home. So we can be guiding you like it will be like telementoring. We'll guide you from outside, but you will have the confidence with a nurse standing beside you that you will be able to change it. Because I completely agree that getting them with a ventilator support and all those catheters to the hospital is going to be very difficult. So if the stoma is healthy and you are using all the precautions and you've trained yourself well enough and you have a supporting person with you, you can change tubes at home, but not the first or the second time because these are usually difficult in the initial few times. Then as you get trained and as the stoma develops a good skin, like how my nose has a skin here, my ear has a skin here, gradually your tracheostoma will develop skin around. Then changing the tube is easy as I showed in the video. So this is what I would recommend.
Thank you, doctor. Sebastian has a question. Is there any speech improvement exercises or physical therapy for pals who getting to lose the ability to become weak or have strain too much when they get tired? So this is any speech improvement exercise and physical therapy.
So first, what we recommend is start training the lung very early, because once respiratory muscles start getting involved in the disease process, then lot of swallowing and speech will get automatically affected, even if the tongue muscles are not affected, because the lung play an important role. So they have to, when the patients are diagnosed with respiratory problems initially, when your diagnosis is on paper, you start training them for respiratory muscle exercises. Then if the tongue muscles get involved, swallowing becomes an important issue. So if everyone around is a speech therapist or a physiotherapist, they will understand that supraglottic swallow exercises will help them a lot. Forward chin and prevention of aspiration maneuvers will help them a lot. So start training them very early before they actually go into the phase of aspiration, or where the actual muscle paralysis sets in, that is stage 3. So when they are at stage 2, when weakness sets in, at that time you start training them. It will help them prolong the phase of stage 3 where actual paralysis sets in. So this is what I would recommend.
And the last question from the list, there may be other questions from the other team members, but the last questions on the list is from Mudassir. Best remedy for neck drop.
Okay, so neck drop is difficult because your muscles on the neck start losing power, and the patients have neck drop while walking or while working or doing something. So the easiest way is to use a neck collar. Okay, patients with tracheostomy, there are special neck collars which are available which have a hole here. So that those neck collars can be used for these patients so that they keep on communicating with a tab in front of them and they don't have this neck drop frequently. So they can wear these neck collars at home, and even when you are mobilizing them, you can use a special neck collar made for these patients with tracheostomy. These are easily available because these are the same neck collars that are used by cervical spine patients who develop trauma to the cervical spine and have to undergo tracheostomy. So these are easily available with the therapists. So I think that would help them in a great way.
Thank you, Doctor. And at this point, I will hand it over to Satwinder. If there are any questions to be asked.
Thank you, Prem sir. Thank you for asking all the list questions. Anyone else like to ask any last question from this meeting? Shivangi, Purab?
Yeah, I have one
Please.
question to ma'am.
Yeah, please go ahead, Purab.
Yeah, hello ma'am.
Hello.
Ma'am, my name is Pura. My father is suffering ALS since last 3 years, and he is on tracheostomy almost since last 5 months. Uh, we are observing that in last 3 months he is improving bit in terms of taking oxygen and breathing capacity, and he is maintaining even. We are giving BiPAP almost around 11 to 12 hours, because he even doesn't need much. But for a rest purpose and while doing the sleeping, we are giving him BiPAP. Now, my
Yeah.
question is related to speaking valve. Since he doesn't have much secretion, what we have seen in past, and before doing tracheostomy, he has little bit ability for speaking. But after that, we didn't see that how he could able to speak, and also if he and even in his current vitals are good, the health reports and blood reports are good. So if we want to start that practice, so what step we supposed to follow?
Okay. So first, is he on a cuffed tube or an uncuffed tube?
Yeah, cuff tube.
Cuffed tube. Can you keep the cuff deflated for some time?
Yes, yes.
Yeah, without him increasing any increase in secretions or him going into distress, you can keep it deflated for some time.
Yeah, we've tried only for once while doing the suctioning, but we never kept kept it for longer period, like 10 minutes or 15 minutes, because we do not have that knowledge on that particular area.
Confidence. Okay, no knowledge. Okay, so you can, if you have a therapist with you, you under the guidance of a therapist, you can deflate the cuff and observe
Yes.
your patient for 10 minutes or so, whether there is increase in coughing, increase in the
Mm-hmm.
suctioning. Okay, whether this sound sound increases,
Yes.
that means some secretions are going down. If these are
Mm-hmm.
not there, then you can start using a orator valve or a speaking valve. Okay, the
Yes.
company is Smith. I can forward the company name, or it may be available in your group. You can use that valve. If he uses that valve, he inhales. When he breathes in, it opens. When he tries to talk, it closes. So air
Mm-hmm.
pushes from the lungs around the tube and goes up, and he vibrates his cords and he can speak. Okay.
Okay.
The hindrances would be that the tube might be of a larger size. So there is no space around the tube for him to pass the air above. So
Mm-hmm.
sometimes if a smaller tube is used, then it gives more air, more space around for air to pass. Okay,
Right.
so we also would want to know what size of the tube is there, and if whether the size can be reduced by 5 mm or not. If it can be reduced, then the speaking valve will work better. Okay,
Mm-hmm.
and you can, if is using the uncuffed tube for a very long time, you can then remove the cuffed tube and put an uncuffed tube also. But if he needs cuff inflation intermittently during speeds or something, then of course you can't remove the cuffed tube. Then your speech will be always intermittent. Only when you can deflate the cuff, that time he will be able to use the valve and will be able to speak. Whenever you are using the BiPAP, he will have no speech because the BiPAP will push in air so much that he won't be able to push air above between the cords for him to talk. So at the night time, he won't be able to speak because you are using the BiPAP. But in the daytime, you with trial and error, you will be able to, with the help of the therapist, deflate the cuff for some time and use the valve, and he should be able to communicate for a little while.
Okay. Sure. Fine. That's clear. Thank you, ma'am.
You're welcome.
Any other?
Hello, ma'am.
Yeah, please.
Ma'am, we are using nebulization medicines also, like Livolin, Duolin, Buracort, Buracort. So which one, which we can use on daily basis, which when we have to use on thick secretion or when for infection? You can name some.
Okay. So the names that you are saying are all bronchodilators in some way or steroids. So these have no role in reducing secretions. They are to increase the lung capacity. So your neurologist or your physician will be able to tell you which of these drugs are needed for your patients. From an airway point of view, from an ENT side, to take care of the tracheostomy, you need only normal saline. You need nebulizations only with normal saline. You without a doctor's recommendation, you should not take any antibiotic nebulizations because these can cause some spasm in the lung and affect your patient's breathing. Duolin that you are talking about, the next drug that you said, Budecort, all these are for the lung, not for the tracheostomy care. So I can recommend only normal saline for you. Sometimes there's a drug called Mucomix. When the secretions are too thick, we ask them to take a nebulization with Mucomix, and Mucomix nebulization should be followed by a Budecort neb because Mucomix can also cause some lung spasm. So Mucomix followed by Budecort can be given only in case of thick secretions. But for the rest of the nebulizations, you have to consult your physician.
Okay, thank you so much.
Well,
So anyone else has a question? No, I think you have covered it all with the best, I think, way, and it's very knowledgeable session. And it's really, I was fortunate to meet you in the neurorehabilitation conference, and really, really great of you that you accepted the invite for our ALS care and support group. And I'm sure those people who have not been joined, they are going to watch this recording also, because you can understand the routine of CALS taking care of ventilator and BiPAP patient, which is mostly tracheostomy. So I'm sure that more people will watch and get more knowledge, and very good knowledge which you have shared. Thank you so much.
it was my pleasure and indeed my honor to be part of this group. And you can share my number, and if there are any other questions, my email also with anyone in your group, and in any way, if I can be of a contributing help to your caretaking, then it will be a great pleasure to me. Thank you so much.
Thank you so much. And the way you said that camera and the person can changing at home and you do that this is really, really amazing that this kind of service and the knowledge sharing you are doing for these patients and for taking care of tracheostomy at home. Prem, you were saying something.
Yeah, no, I was just thanking Dr. Choudhary. This was an excellent presentation and a lot of good information you shared with all of us. So thank you very much for this presentation, and we will continue contacting you for future problems and situations. Thank you.
Thank you.
My pleasure.
Thank you.
Thank you.